Good afternoon, and welcome to HealthSystemCIO.com All-Star Panel, The Dirty Little Secrets of Big Bang VNA, a webinar tweet chat combo from HealthSystemCIO.com sponsored by Vital Images. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I'll be your moderator today. We are hosting a tweet chat, simultaneous tweet chat that you can see in your media viewer panel on the right-hand side of your screen. It's hosted by Kate Gamble, our Managing Editor and Director of Social Media. You can participate in a separate browser or by using your phone and the hashtag HSCIO chat, or you can simply view it in the media viewer. And we'll have some things going on in your WebEx panels. As I mentioned, the tweet chat. We'll be doing a couple of polls during the event, and you can see that in your polling panel, and you can submit a question in the Q&A panel. Leave the default set to all panelists, and we'll take those later in the program, but you could send them in as they occur to you. And you could download the deck by using the URL on your screen, and there's a shortened version of it on each of our slides. Just so you see how we're going to spend our time today, we're going to go about 35 minutes with our main panel discussion featuring Todd Richardson, SVP and CIO at Aspiris Health Network, Joe Marion, Principal of Healthcare Integration Strategies, and Jim Pullman, Enterprise Marketing Manager with Vital Images. So without any delay, we're going to jump right in and start our conversation. So let's get an overview of everyone's organization. Todd, would you go first for us?
Sure, thanks, Anthony. Aspiris is an integrated delivery network. We're in central are headquartered out of Wausau, Wisconsin. Our facilities, we have 8 hospitals and about 56 clinics, long-term care, scattered throughout north central Wisconsin up to the upper peninsula of Michigan. So from one end of our coverage area to the other, we're about probably 4.5, 5 hours from one facility to the other. So we do cover a vast network. And being in northern Wisconsin, we have pretty poor coverage from a connectivity perspective. So our overall connectivity is challenging when we get up into the Northwoods. From an organizational perspective, we've got about 7,000 employees, again, over those systems. That's a pretty good coverage area for us.
Excellent. Joe? Thanks, Todd.
I've been in healthcare for about 40 years and primarily consult in PACS and enterprise imaging related topics. Spent a career with General Electric in PACS and CT, and have been consulting on my own for over 20 years. I've done probably in excess of 100 PACS engagements for both radiology, cardiology, and enterprise imaging, and have several current projects going involving large IDN environments as well as single hospitals.
Very good. Jim, a little bit about Vital Images.
Sure. We're Vital Images. We are a part of Toshiba Medical Systems. We're very well known in the 3D viz space, and more recently have introduced a number of informatics and analytics products to the marketplace, and I have the privilege of being marketing manager for some of those products.
Very good. All right, we're going to start with you, Todd, on this one. Why does it seem that healthcare is moving away from the traditional approach to archiving with radiology and cardiology packs?
You know, when you look at imaging, you know, in general as a broad term, you know, you certainly got the imaging within radiology and cardiology. You've also got, you know, a number of other areas in the organization that have images that you need to be serving up. You know, and when I got into this business 25 years ago, we had a lot of niche solutions, department by department, non-integrated silos of data that existed throughout the organization. And so from an IT perspective, we're constantly keeping each of those systems current, trying to provide access to the right providers, either in the radiology case, the radiologists themselves, then you start pushing out of that that department out to your providers throughout the organization. There's a need to have access to that data. As we've moved into the electronic medical record, there is just this expectation, as it should be, that you've got access to information and data and images, you know, regardless of where you are, whether you're in radiology looking at a PACS workstation, whether you're out on the floor, whether you're in a clinic, whether you're out to dinner and you're looking at something on your phone or iPad to take care of patients. Having those images locked into a single product, regardless of the name that's on the front of the PACS system itself, regardless of the vendor it comes from, we basically find ourselves as CIOs and as health systems kind of held hostage to this data. And times change since I've been here. As I got here, we were converting PACS systems. Huge cost from the ability to migrate that data with those proprietary wrappers around them, move them from product A to product B, just go to PACS from PACS. And the cost of the storage associated with that typically is you're buying that storage from the vendor themselves who brings you the PACS system. So you find yourselves with all these different storage platforms that are sitting out there. From an Aspire's perspective, we are moving to more of a consolidated system integrated perspective, and as we are growing and bringing on additional facilities, we find ourselves, I mean, right now I've got 4 different PACS systems. Now, trying to serve up those images to everybody, it really puts us in a quandary on how best to do that for the providers. So if I'm a physician trying to take care of a patient, I would, you know, my day is centered around my electronic medical record. We're an Epic shop. So as I'm in Epic, I want to be in Epic and I want to be able to see everything and serve everything up. If I'm forced to try to integrate to 4 different PACS systems, you know, that creates technical challenges for us, first and foremost. We've got cost issues with having all this proprietary storage. As I move from vendor to vendor, if I decide to take out a PACS system, put in a different one, I'm stuck with these conversion costs. So as we just start looking at the costs, so 2 big drivers, cost and access to the information really are the drivers for us, and trying to take and pry away that proprietary wrapper that the PACS vendors will put around their images in their own system, take it out of there, put it into a vendor neutral archive, so regardless of which PACS system I may convert to at any point in time, my data stays there and I don't have to incur the cost associated with those conversions. It's certainly easier to keep upgraded, you know, in a single platform, and the ability to serve that single image up to my providers, either through a link in the EMR or directly through a universal viewer, some way to just make it more simple for my providers to get access to it, as well as for the technical folks that have to support it.
Excellent. Joe, any thoughts on the question or what Todd said?
Yeah, I think one other aspect of it, which IT certainly has concerns about, would be the economies of scale. So if you have to support 3 or 4 or 5 different architectures or infrastructures, there's a lot of opportunity in the context of getting to one infrastructure, having one service maintenance agreement to deal with, as opposed to having to deal with multiple.
I totally agree. If you've got to if you have a fat client, perhaps, or something that's required on a device, and I got 4 of them, the need to have things work together and keep it from breaking every time you do an upgrade, you just have more moving parts. So if you can simplify the environment, it makes it a lot easier, and you're right on track.
Excellent. All right, let's stick with you, Todd. At a high level, what are some of the costs associated with implementing a VNA strategy, and can they be justified? Is there real ROI?
I guess we'll see. Certainly from the vision that we laid out, and you can lay out what those costs are that you're incurring today. And yes, it's going to cost you to move to a new system, but all things cost, and so we've tried to do a good job of, trying to lay out some of those softer costs as well as the hard cost of storage. I mean, you got to buy storage, you might as well buy it as cheap as you can. From an economies of scale perspective, if I'm buying a whole bunch of storage from a single vendor, I'm going to get it at a cheaper price when I can shove everything into that, because I'm going to have more than buying little bits of storage from multiple vendors. The costs, from a physician perspective, that workflow and quality of patient care, it's more difficult to put a cost on that, but that certainly is a huge player. When you can set a vision out and invite your physicians and have them as a part of the implementation or the process of due diligence and looking at a vendor-neutral archive, very clearly they become champions for you and help you with the sale. I think we do need to do a good job of trying to put as much hard numbers in because we're all being held accountable for the cost of our budgets and what we're spending on it. It's not an insignificant spend, but I know the last conversion we did, we spent like $700,000 just converting images from one PACS to another PACS. That has nothing to do with the software or the implementation cost of the system itself. It's just data conversion. And there's very little value from my perspective in data conversion, but I have to do it. It should just be an image. I should just be able to read it. It'd be like taking a JPEG file. You would expect to see that on any product, and I get why they do it from a performance perspective in many cases, but those are costs, so I think you need to take a look at the hard cost as well as the soft costs. If you can make it a wash, certainly in the short term, I think if you start looking in the long term, there are certainly some savings out there. And I'm sure Jim or Joe could speak to it. Having done it more, we're in the very beginning stages, so, you know, again, we'll be keeping track of these as we go and trying to justify and show the organization what we've done.
Jim, Joe, either you want to jump in on that, or should we move on?
Sure. Just quick factor is also the question of redundancy. So if facilities are starting to look at redundant data centers, obviously having a single infrastructure that multiple applications can use is going to be much more efficient and advisable than having to support multiple environments.
Great,
and the whole cloud.
I was just going to say that was Joe. I just want to make sure we identify you for the audience. That was Joe. Go on, Joe.
Okay. The only other point was just that cloud-based environments as secondary storage are also becoming more important, and I think those need to be factored into the equation, cost equation as well.
Very good. Very good. All right. Let's talk a little bit about migration. We hear that some VNA projects require migrating all data into the VNA to provide enterprise access. Isn't this expensive? And are there alternatives? Jim, let's start with you on that.
Sure. And in the end, really, part of your approach is to be able to serve up images and clinical data quickly to physicians. And those physician users don't care if, you know, they don't care what the source of that data is, if it comes from a VNA, if it comes from another PACS system. They just want to be able to get the information they need when they click the button in the EMR. So I think to approach it from a hybrid point, the one piece of it is when you perform data migration, especially if you've had a PACS system or two for quite some time in your enterprise, you have terabytes of data that need to be converted to different formats, and it can take quite a while. And these, there are technologies that can be put in place to help bridge that availability. So number one, to look at workflow tools that actually can take advantage of DICOM Web is a great alternative to put immediate and quicker access in place, and also to run your VNA migration strategy in the background. So we call it VNA on demand, but what it really constitutes is when images are pulled forward, so you get say you get a new CT study done, patient comes in, pull those priors forward, look at them, but then populate the VNA at that time with those older images rather than doing a expensive mass conversion of information. So that's first of all, streaming technology to provide access, and then migration strategy are two different alternatives that can be looked at.
Joe, any thoughts?
Sure. I've also told a number of clients or recommended to them that if they're in a transition from one PACS vendor to another, that another effective strategy would be to implement a VNA early on, VNA and universal viewer strategy, and start moving the data off of the old PACS into the new PACS, and that will help reduce the migration cost as well, because as long as they can get the data out of the old system in a standard format such as DICOM and push it into the new VNA, that's one less study that has to be migrated by the old vendor to the new system. So if you have the luxury of timing, I'm working with one client right now that does have that luxury. They've got about a year before the PACS gets changed out. So if they implement the VNA quickly, they should have a significant amount of that information already migrated.
Excellent.
And that was exactly the strategy we were taking. That's exactly the strategy we were taking. Is we've got 4 different PACS systems. We're trying to, so we have one initiative to simplify and standardize our PACS systems down to a single PACS vendor. So that had its own legs, but when you really start looking at putting a VNA in place with a universal viewer, the real driver and the need to standardize on that economies of scale on the back end while you still have the cost of multiple vendors, putting that vendor neutral archive in place with that universal viewer gives seamless access to the information and to the images from your provider perspective, while we in the background on the IT side are worried about the conversions and the migrations later. That really kind of separates the users from the sausage making that we're doing in the background to get rid of or consolidate those down.
Excellent. All right, let's talk a little bit about storage. Todd, let's stick with you on this. How can health systems predict how much storage they need when the system is implemented and grows over time? And how will multimedia storage impact this?
I think depends is kind of a word that keeps coming up in our discussions. I think the thing that we did was take a look at what is our storage capabilities or requirements today across all of our modalities. What's happening to each of the image sizes as technology increases and your CT images are, you get more and more slices, and I think you go back and look at your cost, your storage over time, and you start projecting those storage amounts out is about all you can do just to look at what you're trending at, and you start seeing it increasing more logarithmically than in the current years than it has in the past. So you kind of have to just look at your current usage if you can take a look at those and then start looking at some projections. And boy, when it comes to multimedia storage, I mean, everybody's wanting to take images today. I mean, everybody on their phones taking images, and they're wanting to shove this stuff into our EMRs or a place to store it. And I think that's where the VNA is going to shine, when we've got a single place to put stuff. In today's world, without it, you're forced to have PACS storage and cardiology PACS storage and telemetry, and you got your wound care that are taking images, and you got people in the ORs taking images, and you're trying to shove it onto a blob server somewhere in Epic or figure out a place to put this stuff. This certainly gives us the right vehicle to start with, and then probably working with the VNA vendor that you're going to be looking at and saying, well, what is the conversion size? And I'm on the technical side, I don't know if it necessarily varies, by VNA vendor, what the size conversion is, but certainly working with them to help project those costs based on history would be my best advice.
Joe, you want to jump in on storage a little bit?
Sure. I think the key factor is, and I've worked with a number of sites, that they wrestle with, well, I've got radiology and I've got cardiology, but they really have no perception, if you will, of all of the other image data that exists within the facility. So the dermatologist that's capturing things on their smartphone, there's just a lot of miscellaneous imaging data that needs to be addressed. Similarly, things like sleep lab, that might be generating video data. These are all forms of imaging data that need to be addressed in the total context. So the more upfront that you can identify, the better that you can estimate the sizing of a device, because the last thing you want to do is undersize the capacity of something and then get hit later on with an incremental licensing fee because your volume has substantially grown. So it's better if you estimate some of that up front.
Anthony, another thing that's is important is work with your medical staff on what you want the life cycle of that data to be. You know, in the old days when we had film and it took up so much physical space, you know, it was easy to implement rules that will only keep certain studies for 5 years or 7 years, or, you know, whatever your local legal requirement was. But it really to plan that up front, what the life cycle of that data will be, and then to actually purge some when that life cycle is hit.
And having those rules set up front, because I tell you, it's certainly a lot easier going in, especially if you have to do a massive conversion. Why would you want to pay for a conversion of data that, from a data retention policy perspective, you shouldn't need to convert? So make sure you got that data retention policy updated, and then as you start your conversion, that can be your guide. You know, if you go ask a physician how long do you want me to store it, their answer has always been forever. But I think if you take that, it's easier to implement that right up front than send a message out to everybody saying, by the way, we're going to go out and get rid of all of our data that's older than X. It's better to have it in place up front than have to come back and do that later.
All right, very good. Let's talk a little about vendor comparison. I want to start with you, Joe. How can health systems compare one VNA vendor to another, and are there certain VNA features that are particularly important to consider to ensure a health system is successful in implementing an enterprise imaging strategy?
It's largely a function, Anthony, of what the intended application is. So in some instances, you will find people that simply are looking for a replacement of, say, a radiology or cardiology archive, and therefore they only really have to worry about DICOM type data, and the extent of maybe the rules or the communication of the archive might be lesser factors, whereas there are other facilities that are ready to begin looking at it from an EMR perspective and an interface to the EMR. And in those types of environments, you're obviously going to be addressing more than just radiology and cardiology. So having the ability to support multiple formats, having the full rule sets in the sense of image life cycle management, as well as media management. So oftentimes these systems can, in the background, be migrating from an old media to a new media, which is important as changes in technology occur and improvements and economies of scale of that media. So it's, I think, most important to have an understanding of what the requirement is and then assess how well the companies can address that requirement. So if somebody is predominantly a DICOM-oriented device and really does not have XDS, the cross-document sharing support, at this point, they probably would not be a good candidate for an enterprise scale solution. So I think those are the key factors.
Todd, you want to touch on it from the buyer's point of view?
You know, it was interesting as we started going through our process. You know, it kind of like looking at a house, right? You go in and you think, oh, this is great, but then you get smarter about it, and then you ask the same questions or look at different features and functions when you start looking, you know, at the next vendor, and there's some vast differences, but you know, between the vendors as you start looking at it. Certainly, the vendor neutral or the universal viewer was a key component for us. From the standpoint that we were looking at it, not just trying to do this great big bang, flip it on one day and everything's there. So, and I guess much like you look at any other systems, it's reference checks, it's calling your buddies that are other CIOs elsewhere that have already been through it, finding out what what they went through, what's the good, the bad, the ugly. And I think as I've, talking with our vendors, you're always going to have issues. You're going to have challenges. It's not that you're not going to have things that pop up. It's how you handle those. So certainly having a partner to work with as you're working through the challenges is important.
Very good. Let's stick with you, Todd, on the next question. What tasks are your staff going to be responsible for in terms of implementing a VNA? How much of their time will it take? Are there certain professional services you need to outline in your contract?
As we started going down our process, and I think it really is every organization looks at how they're currently structured. Within our clinical informatics department, we're creating an enterprise imaging team. So we've got a dedicated group of informaticists that are working in that space with imaging, not focused specifically on one modality, but really is taking a look at imaging as a whole. And I think certainly as you're working through the process, and probably back to the previous question, working with those vendors, what is it we're responsible for? What are you responsible for? You're certainly going to have to take care and, be responsible with that integration to your EMR from an HL7 perspective. Perhaps migrations from other systems working, your staff's going to have to be a part of that, working with the VNA vendor to help with that integration. We will take on our staff training. I suppose some may do that for you. We chose to, do that ourselves. If there's any, software, hardware prep, depending on how you roll it out, that needs to be done on your end, depends, keeps coming up, right?
Yes.
So I think you work with the partner to outline that up front so you understand what that's going to take. What's a realistic listing of the tasks, who's got to do it, how much time is it going to take, and the time will depend. If it's conversions, it's how many terabytes of conversion do you have. If it's an EMR vendor integration, it's what, if you've got an engine, if you're going directly to the EMR vendor, what are your system capabilities? Do you have to outsource any of that? Certainly working through all that testing, making sure, you know your environment. I would rather have my staff doing that integration testing and making sure that we've done the scenario testing, that we've got it figured out, because, you can hire professional services with the best intentions, and they just don't tend to know your environment or all the idiosyncrasies of that testing to make sure that everything's going to, really turn out the way you want it and uncover all those rocks. So, you've got to take personal responsibility for the implementation, just like you would with any project. Managing the project itself, I'd say, be the big ones.
Very good. All right, now we're gonna put a poll out there. I'm going to open it up right now. So you should see that on the right-hand side of your screen. For sites that have implemented a VNA, did you leave your radiology under a cardiology PACS in place? Just select one of the answers. We left our PACS to do diagnostic viewing, but migrated all our archive data. We left our PACS, but we were importing older studies to the VNA as they are used as a comparison, or we migrated our data and decommissioned our legacy PACS. So you can go ahead and answer that question. I'll leave that poll open for a couple of minutes, and we'll discuss the issue. So, to our panel, will a health system have to keep its radiology or cardiology PACS once it installs a VNA? And we're going to go with Joe on this one first.
Okay, Anthony, I think the key point here is that it's going to depend on the architecture and configuration that one implements. So there's a term that's being bandied around in the marketplace these days called deconstructed PACS, and you'll hear that a lot in the context of why I no longer need a singular PACS vendor. And a lot of that early on is applied to the VNA and the universal viewer, but more so in the context of workflow applications. So if one goes in the direction of a deconstructed environment, then if you address the workflow aspects of the individual service lines, it is possible to do or not to maintain, say, a legacy radiology or cardiology PACS. And if that's not something that one wants to do, then maintaining the legacy packs does provide some redundancy in the context that, let's say that the radiology packs needs to be taken down for a day for an update, or there's an issue. If I have a separate VNA and universal viewer, then the rest of the hospital environment can continue to operate and access images. Whereas if I do the deconstructed approach and I'm dependent on the VNA, if the VNA goes down, then literally everything is down. So there's different strategies that I think can be applied. So it's not a given that you can directly replace an existing radiology or cardiology packs.
Jim, any thoughts?
Yeah, you know, the reality of departmental packs is that there's a lot of years have gone into perfecting the workflow for radiologists or cardiologists. You know, sophisticated hanging protocols that can be triggered by exam type, special integrations to either structured reporting tools or dictation systems. You know, those kind of very finite clinical workflows can't be replaced by a universal viewer strategy. So, you know, the VNA people consider should be strong enough to form the back end across multiple different types of packs, but you know, and I hate to echo depends again, but it really depends on the clinical workflow that's going to be answered. So there's a lot of value to keep the high-end, high-efficiency radiologist workflow tools, but integrate them against a common back end.
All right.
And Jim, this is Joe Marion. Just one more thought to that. Yeah, I once had a situation where a customer was basically asking that in the context of, well, I don't need a PACS vendor any longer, and I raised the very simple point of 3 radiologists, 3 workstations, they all simultaneously sit down and access the exact same case at the exact same time. Which report do you accept? And there was sort of this deer-in-the-headlights stare as to, well, what do you mean? And the point was is that most PACS have, as part of their workflow, the ability to decipher who has opened a case and who is reporting a case so that others don't duplicate a report of that particular case. And I think that's a very simplistic example of those kinds of rule sets or workflow examples that people need to be cognizant of.
Okay, well, we've got our poll response, and I shared the response with the audience. 17% selecting answer A, 33% selecting B, and 33% selecting C. So there are our poll results. All right, let's move on to our next question, and we're going to go with Jim on this. If the radiologists who read for a hospital have their own imaging center and PACS, will the hospital be able to share one VNA with them?
Yeah, from a technical point of view, and it's something you want to run by your VNA vendor during your contracting, but there is no technical reason why you can't create security profiles for the different users that, you know, allow a shared environment on the technical side, but on the clinical side, limit who has access to the appropriate data. Now, of course, there are legal considerations to that, and depending if the sharing group is actually an employed entity of the providing hospital, or they're a contracted entity, you know, you have to pay close attention to the details of the Sunshine Act and any local laws governing physician compensation in your area. But from a technical point of view, it's an expected capability of a VNA.
All right, very good. We do have an audience question, so I want to jump down and take that, and then we can go back to where we were. Have you had any experience, let's go with Joe on this first. Have you had any experience with conducting a hybrid migration where in addition to image data, older metadata is migrated, moving only the records and allowing the image data to flow with normal VNA workflow? That's from the audience.
I'm not sure I totally understand what they're asking in the context that from a hybrid perspective, if you're talking about moving old data as well as current data, I think the key factor is the metadata and the patient demographic. So if the older data is what some people will refer to as clean data, where the demographics are capable of being matched up, then that's probably effective. In an older environment where, say, the PACS did not have a risk associated with it, and there really isn't a good matchup of demographic data, it's a much more involved and manual process to make sure that the demographics match before you integrate that data. So I don't know if that answers the question of what they're looking for. Maybe we'll get some clarification, or Todd or Jim, do you have some perspective to that?
Yeah, I think you'd answer it about as well as I could answer it, and I think that would also peel back to the previous question about using, an imaging center and sending their data in. It would be the issue of how do you link those images up if you'd want to make sure you have some sort of an ADT feed or some sort of workflow, so you don't just have images showing up in a VNA that aren't associated with a patient, and being careful on those start things. But yeah, that'd be my answer on this question.
Okay, very good. All right, let's jump back to our questions. If any other questions, if you in the audience have any other questions, please go ahead and send them in. Todd, let's stick with you on this. If a health system has low bandwidth connecting some of its hospital sites, will a VNA help with image transmission speed?
I think it's, and Jim and Joe probably better to answer it from what they've seen historically. We're just doing it now. I think how you architect things, we've got 8 hospitals, I mentioned, some in the UP of Michigan with relatively small bandwidth back to us. If, set the VNA aside, if you choose to have your PACS system and your PACS servers and everything's back at a centralized data center, you're going to have the same. You're going to have bandwidth constraints moving big chunks of data. So depending on the size of it and how big those images are, your bandwidth is obviously going to continue to be an issue that you're going to have to keep an eye on, and then that goes to a lot of the prefetching and what you have, back in a centralized data center and or out on the the edges in those local facilities. Many today are going to cloud-based solutions, so again, you've got that aspect to figure as well. But I would probably defer more of the historical, what have they seen, to Joe and Jim on this.
Who wants to jump in there, Joe?
I'll jump in. I think I agree with what Todd said in the context that it's hard to necessarily say that the VNA is going to have an impact on transmission speed, because transmission speed is what it is based on the bandwidth that you have available. I think that's the key factor is that if you're talking about, say, I want to push images into the VNA and they're not clinically critical for clinical purposes, then I can sort of do that in the background and maybe get by with a lower bandwidth. If it's clinically critical to diagnosis, then obviously I think the issue is going to be perhaps upping the bandwidth to be compatible with expectations. So again, I think it's understanding what your requirements are and designing an architecture around those requirements.
All right.
Yeah,
Go ahead, Jim.
Yeah, Anthony, I was just going to add too, and it's to look at what the clinical need at the access point is, and then, you know, like Todd said, a lot of places with multiple PAC systems, you probably have multiple choices on different viewers you can use as the end user, or at least which clinical system they get attached to. So, you know, possibly looking at putting a universal viewer in place that takes advantage of DICOM web technology, you know, that has inherent lower bandwidth requirements, it might be a solution to this kind of situation.
All right. Let's jump down to our second poll question, and we'll get that out to you now. You should see that in your right-hand screen. And this is select all that apply. A successful VNA implementation means what in terms of outcome? Ability to decommission departmental single-site PAC systems, being able to provide a longitudinal patient record across PACs with decommissioning, ability to view both DICOM data and non-DICOM data from a single work list, ability to see patient images from any site linked to the patient record. So go ahead, take your time and answer that with your opinion of how many of these need to be included for success. And we'll go back here to, while you're answering that question, we've got a very technical question here, and I think we're going to stick with Jim on this, and then we'll go to Joe. What kind of technical standards should a VNA meet, such as DICOM or IHE?
Yeah, so that's, and really I think Todd did a nice job of summarizing it earlier. It's really to look at what types of clinical data objects you want to store in your VNA. You know, initially, DICOM, for all the customers that we deal with, DICOM seems to be the initial focus of the project, consolidating PAC system either across entities or across clinical domains. But then it quickly changes to a discussion about documents, media, and other things. And you really have to look at the standards that the VNA is architected on. Everyone expects a DICOM at this point. I think DICOM Web is also another key.
Okay. Joe?
Yeah, I think I concur with Jim saying. I think also what's important is to look at if it's strictly radiology, cardiology type data, then DICOM is probably appropriate, but clearly the IHE, integrating the healthcare enterprise extensions, and specifically the XDSI, the cross-document sharing imaging standard, is going to be increasingly important as other imaging areas are added to the VNA. So if you're going for an enterprise strategy and you want to be able to pull in JPEG and bitmap and other types of image formats, or TIFF, then dealing with the XDS is going to be important. And then the other aspect of it that's, I think, also vital is if the VNA is going to be more of a focal point and interactive with the EMR, then it needs an HL7 interface, or potentially take advantage of the emerging what's called FHIR, the Fast Healthcare Interoperability resources, to communicate with other IT infrastructure. So very important aspect is that, let's say I have 4 or 5 users of the data repository, and Mary Smith gets married and is now Mary Jones. How do I individually go into each of those systems and update, or can I, if I have an HL7 or FHIR type interface to the VNA, then the VNA might be able to be updated and communicate out to the individual devices that the metadata has changed. So I think besides just the imaging formats, it's also important in the context of some communication formats for the VNA.
Very good. All right, let's look at the poll results and put Todd on the spot. I just shared those out with you. So if we look at that, defining a successful VNA implementation. So 25% include first answer, the ability to decommission our departmental single-site PACS system. So that's the lowest number there. Then, and it goes up from there. So the second answer, being able to provide a longitudinal patient record across PACS with decommissioning, 42% say that's part of being successful. The third one, we're up to 75%, ability to view both DICOM data and non-DICOM data, and 100% think answer 4 must be included if you're successful, ability to see patient images from any site linked to the patient record. So again, we go up, Todd, from answer 1, 25%, answer 2, 42%, answer 3, 75%, answer 4, 100% in terms of including those in a requirement for being successful. What are your thoughts of those results?
I mean, I think it represents different people's perspective on what success is. I mean, we never went into it thinking that we would decommission our PACS system, so that was just never a thought in anyone's mind. Personally, when I took the poll, I didn't know it was. I thought it was one of the 4, so I was finding hard time finding one that was exactly mine. I didn't know I could pick multiples. But so yeah, if somebody's dead set on picking on it, they would want to do that. To us, it wasn't a requirement. And I think as we move up, I think it starts to speak to the real purpose from a VNA perspective is to start getting those images out of being locked into a single modality sitting around your organization and putting it into a vendor neutral archive, just to have it into the, decoupled, if you will, and having those various kinds of images that we spoke of throughout the call available to us and linked to that patient. And again, at the end of the day, we have patients being seen by providers, and those images are just as much a part of the record as lab results or documentation. So having that be a seamless component certainly should be an outcome, and I think the poll shows that out.
Okay, so that if you knew you could, if you knew you could have selected multiple, would you have selected 3 and 4, like most people?
I would have selected C. I wouldn't have selected B because that was to me that as I read it, it implies decommissioning, which we just don't tend to be doing.
So yeah, most people who answered the poll thought C and D needed to be a part of it, and it sounds like you're in agreement with that.
I would agree.
Okay. All right. I think that is about all we had time for today. Yes, we're at 50 minutes after the hour. I think it was a great discussion. When you close out your WebEx viewer today, you'll see a quick survey pop up from us. If you could answer that, it'll take you less than a minute. We appreciate it. I want to thank our panel, Todd Richardson, Joe Marion, and Jim Pullman. And I want to thank Vital Images very much for sponsoring this event and making it possible. You'll receive an email when our archive recording has been posted to our YouTube channel, so keep an eye out for that. Attending our events gets you 1 CEU for the CHIME CHCIO certification, so let CHIME know where you were here, and if you've asked us to do so, we will. Sponsorship opportunities, you can contact Nancy Wilcoxon if you need a certificate of attendance for whatever program. We'll give you CEUs for being with us. You can use our final slide in this deck. And you can go to our website to see our upcoming schedule. So once again, I want to thank our speakers, our sponsor, our attendees. Everybody have a wonderful day. Thank you.
Thanks, Anthony.